Assalamu alaikum, the communication day. First scenario, your role, you are the doctor in the ward. Mr. Eric Lupin has long-term diabetes with recent hemoglobin A1C 8.5, complicated with retinopathy, nephropathy. He's on metformin and glycoside. The consultants stopped glycoside and decided to start him on insulin. Now the patient doesn't want to start insulin. Sit with him and address the concerns. Ready?
Yes, Dr. Basim.
Here you go.
Hello, good morning. Hello, good evening. I'm Dr. Musa, doctor in the clinic today. Doctor in the ward today. Let me confirm you. You are Mr. Eric Lubin.
Yes, doctor, I am.
Mr. Eric, how would you like to call you?
Eric.
Eric, okay, Eric. We are here to discuss about your medical condition. Is it okay with you?
Yes, doctor, it's okay.
Before we start, Eric, could you tell me how much you know about your condition to be on the same page, please?
Actually, doctor, I have this high in blood sugar and I'm taking medication for a long time. And I came to do some blood test and they did check for my eye and also they did check for my motor work. And I want to know the results of my test.
Do you expect anything, Eric, about what will you do in this meeting?
No, doctor, I'm just worried about the results.
Actually, Mr. Eric, the results show unexpected result. The result, we did a test which monitor the blood glucose controlled in the previous 3 months, and it seems it is increased. Are you aware what is that meaning?
No.
Okay, that's meaning, Mr. Eric, that your medication, there are a lot of causes. One of the causes you are not compliant with the medication. Maybe you are not in optimal lifestyle control, like diet or exercise. So can I know if you have any of these?
Actually, doctor, I'm taking my medication regularly. I'm taking it regular.
So it is good thing, Mr. Eric. I wanted to assure you, I want to warn you about diabetes. Diabetes is a disease. You can make diabetes like your friend or enemy. So it should be controlled. First, you have to control your diet. So I can refer you to dietitian, can adopt your healthy diet. Also, you have to do some regular exercise. So I can refer you to exercise counselor. He can do some exercise training for you. Also, according to your result and your condition, the consultants recommend to stop the medication, glycoside, and escalate it to insulin. How do you think about that, Mr. Eric?
Yes, doctor, but I don't like this medicine, doctor. I don't like the insulin.
Can I know do you have any concern about insulin?
Yes, doctor. I am very busy, doctor. My lifestyle is not regular. I'm working as a sales manager. I'm going outside regularly. And I'm eating outside. Sometimes I'm eating, sometimes I'm not eating. So I think insulin is not suitable for me.
I understand your concern, Mr. Eric. But as I mentioned to you, diabetes can be a killing disease if not controlled well. So you have to control your diet and do some regular exercise. If you can't do exercise, you can do like stretching in your job. You can walk to the job instead of using a car. You can go to the market instead by walking instead of your car. So it is important to control your risk factor beside the medication, because we have to replace the protein which is deficient in your body, which is insulin. I wanted to how do you think about that, Mr. Eric?
Yes, doctor, I can try to do some exercise. I will try to control my diet. But insulin, I don't like insulin, doctor. I'm not willing to take this insulin.
And I do understand your concern, Mr. Eric, but I wanted to alert you that diabetes can be a killing disease. It can affect your eye. You have now eye affection, so it can affect the eye up to blindness. It can also affect the kidney, can cause kidney shutdown, and it can you can result in doing kidney replacement therapy like dialysis. And it is I am sorry to you that it will be irreversible. You would be in dialysis forever until we find another method of dialysis. Okay, and also besides it can cause increase the acidity in your blood, can cause coma up to loss of consciousness. So how do you think about that?
But doctor, I have one friend one colleague in my job. He was taking insulin and he developed very low blood sugar and he's in coma now, doctor. So I don't want to pass through this, doctor.
I'm really very sorry for your friend, but I want to assure you, insulin is the most safest drug. The only thing is that you should be aware about what we call in medicine hypoglycemic awareness, which when you have any of these symptoms like any shaking of the hand, any racing heart, any hunger pain, any sweating, you should take any sweet like candy or just juice. So it is important to if you have any of these symptoms, you should have like juice or like that. Besides that, there is a new maneuver or new device like a smartwatch can connect it to a device called continuous glucose monitoring. This device is contacted to your is placed on your arm and send continuous monitoring to your smartwatch continuously. So if you have any low blood sugar, she can warn you. What do you think about that, Mr. Eric?
No, doctor, I don't like insulin, doctor.
Can
And
I
also,
know?
I feel I'm okay, doctor. You told me there will be a vision problem and problem in my kidney. I feel okay, doctor. I don't have any vision problem, doctor. Any other alternative? I can take another alternative. Any other alternative?
I appreciate your concern, Eric, but as I told you, diabetes can be a killing disease. At the time being, you have vision affection, and also you have a kidney affection. As time being, it may be asymptomatic, but with time, it can lead to like blindness or kidney shutdown. So you should control your blood sugar. And according to your concern, any new device? Yes, there is a new device. There is a new device. We can arrange a meeting with specialized nurse, can talk with you about the methods of another method like insulin pump or like that. But at the time being, we need.
No, doctor, no. I mean another medication, doctor. I mean another medication other than insulin. If you can offer me another medication.
I understand your concern, Mr. Eric, but at the time being, you had affection of the eye and affection of the kidney, and we should escalate the medication to insulin. And if you wanted to arrange a meeting with the consultant, he can convince you to take insulin. I will be ready to do that. Let me ask you, Mr. Eric, do you drive?
Yes, doctor, I drive my own car.
Okay, we should assess your vision, and also if you take insulin, you should be aware about what I called you hypoglycemic awareness to continue your driving. Can I know? Do you smoke?
Yes, doctor, I smoke.
Okay, it is advisable to stop smoking. If you want, I can refer you to smoking cessation clinic. Okay, Mr. Eric, do you have any concern, Mr. Eric?
Yes, doctor. So there is alternative to this insulin?
Yes, Mr. Eric, I do understand your concern. Yes, there is alternative, but insulin is prescribed in the best interest of your condition. With insulin, your blood sugar will be controlled. Without insulin, I'm sorry to you that your blood sugar will be not controlled. It will affect your vision, your kidney, and in the future you might have heart attack, any stroke. So it prescribed the best interest of your condition.
Okay, doctor.
Okay, time's up. Well done, Dr. Mahmoud. Dr. Ala can comment now.
Okay.
Based on the skills, okay? In the chat box, you can...
In the chat box. Okay.
There are 4 skills. Means 60 marks, each skill 4 marks. So satisfactory, borderline, or unsatisfactory?
So in the clinical communication, Dr. Mahmoud, he forgot, I think in the scenario he mentioned that the patient did the hemoglobin A1C, and also he did and checked, and he had retinopathy and he had nephropathy. So in the beginning of the scenario, Dr. Mahmoud didn't explain to the patient the results of the test that has been done for him. And he didn't also explore the underlying understanding for the patient of his disease, the diabetes. Okay, so maybe in the clinical communication, we can say borderline.
I agree also, and I will comment on this later. The next skill, clinical judgment. Judge well.
The clinical judgment here, I think maybe satisfactory, because here the clinical judgment is about, because he answered it late, but here the clinical judgment is about the management of the patient. He mentioned already the lifestyle modification and the adjustment of the medication, and the other thing, that the alternative treatment. The patient was in seek for the alternative treatment. He offered that late, so the clinical judgment can be satisfactory.
I think I can minus him here, also borderline, because he said there is alternative, and in the best interest of his condition, I don't think any alternative will help. Only the insulin, because with the age, as you know, the residual or the residual amount of insulin in this patient already wasted.
Yeah, but this case came before, and their comment was that the candidate didn't offer alternative. They minus
what the
the candidate because he didn't offer alternative. The other thing, that the main issue for this scenario, the main ethical issue for this scenario, is the autonomy. Okay, so that the patient has the right to refuse. Yeah, the patient has the right to refuse any medical treatment that we offer, and Dr. Mahmoud didn't confirm this point of view or this information. They are waiting for him.
He didn't offer at the end like approval if he is agreed to take this medicine, or still reluctant.
No, I mean the issue of autonomy, that the patient is refusing the treatment. He should tell him that you have the full right to refuse to take the medicine. He should tell him, we will not force you to take the medicine.
Yeah, but at the same time, he should convince him.
Yeah, he will explain, not convince. He will explain the benefits and the risk. The other thing also, he didn't explain, he didn't counsel about the insulin. He didn't explain the benefits expected from the insulin, and also the expected side effect. The patient is one who raised the issue of the hypoglycemia, and then he talked about the hypoglycemia. He should have also counseled about the insulin, the benefit expected and the risk that can be expected, how the insulin is being given, and also the involvement of the diabetic nurse, and to teach him how to take the insulin. he didn't counsel about the insulin. But the main ethical issue in this scenario, and I saw the feedback in this scenario, was the autonomy. That's why they wrote in the comments that it was the patient very resistant. That's what happened in this scenario. The patient refused completely to take the insulin. And I think most of the candidates were uh, only concerned to convince the patient to take the insulin and being persistent to convince him. No, we should only explain the benefits and the risks associated with taking benefits and for taking and the risks associated with if not taking the insulin. And then he has the full right to take or not to take the insulin. That they were waiting for this to know that you are aware that the patient had the autonomy to take the decision.
Okay, the concern and welfare.
I think the concern he managed the whole concerns satisfactory, and the welfare also satisfactory. But I think the main problem were in the clinical communication and the clinical judgment.
Okay, based on this judgment, he will get satisfactory in 2, so 8 marks for the welfare and the concerns, and 2 marks for the clinical communication, 10, 4 marks in the clinical judgment. However, I'm disagreeing for this. So he can get 14 or 15. Okay, let's, for me, I will comment now,
Okay.
but I don't know the calibration. You said important point that the patient is resistant till the end. So I cannot force him. At the end, I can reassure that it's his decision, and if he refused to take the insulin, this is his decision. Supposed to say that you want to say, right?
Yes, exactly. That was the whole comment in the feedback that the candidate was persistent to convince the patient to take the insulin, didn't offer any alternative, didn't confirm the patient autonomy to refuse the medication.
What could be the alternative in case the patient already reached the level of starting
Mm,
insulin?
They can add another oral medication. They can add the GLP-1 agonist. This is, I think, he's not type 1 diabetes. He's type 2 diabetes. So it's also in the clinical judgment.
Yeah,
So
yeah.
I think
What I know, 3 medication, right? Three oral
two only. He's taking glycoside
No,
and
no. I mean,
metformin.
yeah, yeah. I mean, in the clinical practice, supposed to try 3 medication or 3 types of
Yeah,
medication. If
yeah.
failed and he has all this complication, then he decision for insulin to start. But you don't know really. Will the examiner judge on that, or if you said, yeah, I have to convince this patient, will they give him the good mark? It's risky to say, yeah, he has the autonomy and I cannot force him. At the same time, it's the task to convince the patient to start insulin. I cannot convince him. So what to do? Either to do in this way or the other way. You don't know how the collaboration is. But to be neutral, as you said, I will try to convince him. If he refused at the end, after 3 times questioning why you don't want to take it, after addressing all these 3 questions and find a solution for them. Dr. Mahmoud did a great job by trying to convince regarding the CGM, continuous glucose monitoring, but and also for the other solution, if he's afraid of hypoglycemia, he can have the watch. I think it's application in the phone, Dr. Mahmoud, not a watch.
هو على انا قصدي على سمارت ووتش بتاع
Okay.
ايفون.
Yeah, it's both connected, but the main
Yes.
application on the phone.
Is the phone.
So
Yes,
yeah,
doctor.
it can alarm him. The other thing is important here. Yeah, I want to comment on killing disease. Killing disease. You repeated them 3 times. I don't
Mm.
prefer to say killing one. It's a confronting word. So I can talk about the disease as a serious one rather than saying killing one. So it's serious condition. It can affect the eyes, even stroke, mini stroke. You can talk about these things, coma, and it can threat your life. I like always to say your life could be at dangerous or it will be threatened by this condition. Okay, not to say killing disease, killing one. So the words can affect the sentence or the meaning. Yeah, it's killing one, but the patient doesn't want to hear these words. He like always to be polite, a doctor, and talking in calm without confronting the patient. This is what I want you to do. So if you want to say it's a serious condition which having a lot of complication, whenever it happen, it might harm your life, or it might threat or affect your life or put your life at danger in this way. The way you started the scenario about diet and exercise, it's good, but the scenario sound that this patient already tried all things, and I think he is at the level, or he reached the extent to start the insulin, means that he has lost the reserve of insulin. This is what I expect, but I don't know how the calibration, as Dr. Ala said, usually the case in the exam different from our vision. I don't know how to judge on the calibration. Is it something in the scenario hidden, or the patient is clearly uncompliant to the medication and he's not taking care of his diet and exercise? You don't know. Is it something related to his body or to his lifestyle? So I cannot judge in this unless I had the calibration of this scenario. Anyway, yes, you have to address the lifestyle, the exercise, the diet. Hypoglycemia is very important. Driving, smoking, alcohol. I think you missed the alcohol, right? It's very
No,
important.
I didn't
You are?
miss the. No, no, because the time.
Yeah, good. But try to
Because
address
the
it
time.
early. Yeah.
Mm.
The hypoglycemia is very serious condition, and he had one of his friends had it. Don't say the insulin is very safe or the safest medication. It's not safe medication. If he couldn't take care of it, it can have a lot of complications. So the best way to say it's a good medication in the best interest. It's not
Mm.
safe, but it's something in the best interest for your condition as prescribed by the consultant. In this way, you always say the best interest, and I prefer to start it earlier, not at the last sentence. Imagine the last sentence was the insulin is the best interest of your condition, and this is the task. You got
Mm.
it?
Yes,
So
doctor.
try to start it as a task early before the diet and exercise.
Mm.
If finished these parts, you can talk about the lifestyle along with the smoking and alcohol and driving and so on. So the way
Mm.
you started the scenario, I prefer to make these things at the end, social, and I want to start now about the convince for insulin from the start. This is my task,
Because
and
the task. Mhm.
yeah, and I prefer also to mention it. I have a concerning result with me. It's about your blood sugar within 3 months. All diabetic patient will know them. Okay, he will tell you, "Yeah, doctor, you mean hemoglobin A1C? Yes. You have any expectation about the result?" "No, doctor, I was having this result before. It was 10, 11, whatever. Now you can break the news. Now I had the result with me. It showed that the hemoglobin A1C is 8.5, which means that your blood sugar is not properly controlled. We have, as you know, the diabetes, one of the serious condition. We have to take care of it, the complication also associated with it. And I prefer to from you, and I recommend you to have good control for your diabetes. What you mean, doctor? In the best interest of your condition, the consultant have decided to start you on medication called insulin. Have you ever heard about it? No,
Mm.
doctor. Or he will say, yes, doctor. In this scenario, definitely he will say, yes, doctor, I know about it. One of my friends has this medication and he had the hypoglycemia, and you will go ahead with the discussion, okay? This is what I prefer to do. Whenever or whatever the task is, start with it, okay? And always mention the best interest for a medication you are going to prescribe. He will say to you, no, I don't want. Unless you say to him, it's the best interest of your condition prescribed by the consultant. They like to hear this sentence, okay?
Mm. Okay, doctor.
Okay. But still, you have good mark, either 12 or even 14. It's a good one.
علاء دكتور باسم is very malignant examiner. Really.
I'm not.
Even
No,
you.
I'm not.
Dr. Mahmoud, the good
Really,
thing.
I like
Yes.
I like the scenario. I like the scenario because it addressed different point of view.
Yeah.
Because
Yes.
we did it before, and the patient got convinced at the end. Before we did it before, but this I like this scenario because it gave us another point of view that the patient refused till the end, and they will comment about the autonomy. That your job is
But
to
we should
explain.
respect the consultant
Yeah,
recommendation for insulin.
yes. You will not offer the alternative. You just will tell him that we will have another meeting with the consultant to discuss if there is another alternative can be offered to you.
Yeah. If like that, you
Yeah,
can't say, but don't offer it.
yeah, yeah. You will not offer
Even
it.
if he's resistant. The good thing here, Dr. Ala brought the feedback and the calibration of the scenario, so he knows what we have to do.
Yes.
Okay, if the patient still resistant till the end, you can tell him, okay, I will talk to my consultant. It's your right either to accept or to refuse. It's your right, and I can arrange another meeting with my consultant. And he's in a better position to talk with you. Maybe he can convince you about this medication in this way. Okay. Okay. Thank you, Dr. Mahmoud. Dr. Ala. Now, Dr. Mahmoudin, your scenario, I think, in the chat box. Sorry, Dr. Ala, your scenario. Mrs. Married, 90 years old woman, a known history of hypertension, poor compliance with treatment. She was found collapsed at home and brought to hospital. CT scan of the brain showed a massive intracranial hemorrhage. Her Glasgow coma scale is 3 and she remains deeply unconscious. The neurologist has reviewed her case and confirmed that she is not fit for surgical intervention due to the severity of the hemorrhage and her overall condition. So you will sit with, the prognosis is extremely poor, and the medical team believe that she is unlikely to recover and is expected to die within the next few days. The management plan is palliative care, do not resuscitate. Decision has been considered appropriately. So I think he will talk to the son or daughter. It's definitely not.
Mr. Sami.
Okay, Mr. Sami, the son, address his concern. 2 minutes, Dr. Ala, prepare yourself. I will try to finish the comments quickly in the chat box. Dr. Ahad, very resistant. Yes, I agree. But now we know why he's very resistant. It's a calibration and the instruction from the examiner. He should be resistant till the end. And we know how to address it by offering another meeting, not to offer alternative by yourself. Okay. Another comment from Dr. Hosni. Refuse insulin, does it need to sign refusal sign? So it's not a patient, I think, in the ward, right? After addressing this with the consultant, he will say to the consultant and still he refuse. Now you can ask for the refusal form. Okay. And I think also it sounds that you cannot force him. So still is the decision, and maybe the consultant will have another option or alternative option for him. He can do it in the meeting. So it's not the time to sign refusal. It's not something urgent need to be started right now. Dr. Omar, why he is refusing insulin? Sorry, I didn't join from the beginning. Libra device, we mentioned the Libra device. So he is refusing because one of his friend has coma, hypoglycemia coma. So he's worried, and Dr. Mahmoud already addressed this point by offering this machine or device. Dr. Hasni, thank you. Okay. Yes, Dr. Salma Artin. Sorry, Dr. Salma, we can postpone your turn in another session, okay? We started already. Anyone has a comment before starting the next session?
Dr. Bassem, for the alternative, I think the best approach because having an alternative is part of the informed decision. If you are going to make anything, usually they will they like to hear about the alternative, but you are right, you can't give the alternative from yourself. So if the time allows, you can inquire who made the about the decision for the insulin. If it's made by the endocrinology consultant, then we will be writing back to the endocrinology consultant to let him that you are not wishing to have basically insulin. And then there is alternative medications that will be discussed with you. So you are acted on the patient best interest and patient behalf to communicating his wishes to his consultant. If you are not in endocrinology clinic, if you are in endocrinology clinic, you can say, I can speak to my consultant about this, and we will communicate with you via a letter or maybe today. Did you get my point?
Yeah, I agree. We mentioned that you will let it open. You will not give, and you will not also decide to refuse. So let him or let the consultant sit with him again, or arrange another meeting or another appointment, and the consultant will take another decision based on his refusal. So it's not the time to take this seriously now. You can postpone till the meeting with the consultant. This is what we have said.
Yeah, because I was in the handover, so I didn't.
No, it's okay, Dr. Amal. Yes, it's a good idea. And based on the best interests. I usually say this word, best interests of the patient condition. This decision have been made by the consultant, and if the patient has any idea or another different opinion, let him sit with the consultant. He might convince him, or he will find another option for him. Okay. During the discussion, you will address the other concern. Then the social support, then the occupational. I think the job very important. The Dr. Mahmoud didn't address it, right? Did you address the job, Dr.?
No, in the scenario, Dr. Bassem, he was salesman.
He said, or you mean?
Yes, in the scenario, yes, Dr. Alaa said, I am salesman, I can't do
Oh, okay.
exercise. So I offer to
Perfect.
him
Perfect.
walking to the supermarket like that.
Yeah. I remember this sentence. Okay. Yeah. At least you know it. If you couldn't ask, it will be maybe harming your mark, right? Perfect.
Yes, Dr. Bassem.
Okay. Thank you, Dr. Amar. Anyone has comment before starting the next scenario? Dr. Ala
Just
already?
one thing.
Yeah, Dr. Ahad. Okay.
To be honest, well done. Just I would like to raise the issue of the autonomy. I think this should be raised with the surrogate if he's not convinced after 3 times. So this point should be raised that we will not like force you for anything against your will, and you have the full right to refuse any treatment. But we would like to speak to you again in another meeting with the consultant. So I think the point of autonomy after refusal for many times should be raised with the surrogate. This is the first thing. The second thing about when he asked about the hypoglycemia and that his friend developed hypoglycemia, he just mentioned about the liver sensor without talking about. So as Dr. Basim mentioned that we should speak about the insulin, that it's in the best interest and every medicine has a side effect. And one of the side effects of insulin is having hypoglycemia or low blood sugar. But we will try to optimize that. We will try to give you the dose that is will control your blood sugar, and then you can speak about the liver sensor. Thank you.
Yeah, thank you. Perfect, Dr. Ahad. This is what already prompted. And yeah, it's one of the side effects, but usually we can prevent it. You
Yeah,
can
so
arrange
this is the
another.
point, is
Yeah,
we will give you the dose
perfect.
that will optimize your blood sugar to decrease the
Without
risk of
decreasing it.
hypoglycemia. It's still a side effect of the insulin, but we will try to put you in very optimum dose that will reduce this risk in the future. And then we will kind of speak about the liver sensor and how can we prevent that if the surrogate the patient develop like hypoglycemia.
Perfect. Not only that, you can even include the dietitian to adjust the medication, sorry, the diet along with the insulin. If you are talking about the insulin adjustment, you will take another session or another meeting. So it takes long time. It's lengthy scenario really. but try to be confined to the point and to be targeted during the discussion. Try to make a group of doctors whenever you are talking about such problems. So the group of doctors, including the dietitian, nurse, even the injection of insulin here, you have to address. You have to rotating the area or the site of injection. You have to be careful not to be deep, not to be high. All these things supposed to be done if the patient already accepted. But our scenario today, the patient was refusing, so you cannot address all of these concerns unless he will be convinced. So it will take another session or another meeting, or it could be another station, not in our today station. Okay. Perfect, Dr. Ahad. You open up another point, which is the insulin address. We can start now the second scenario. Dr. Ala, ready?
Yes, Dr. Basim ready.
Yeah, hello.
Hello, I'm Dr. Ala. I'm the doctor in the medical ward today. Let me confirm you are Mr. Sami, son of Mrs. Mary, 90 years old.
Yes, doctor, I'm Sami.
Mr. Sami, you are the next of kin to Mrs. Mary?
Yes, doctor. I'm her brother.
Okay. So we are here to discuss about Mrs. Mary condition. Is that okay with you?
Yes, doctor, please. I want any update about my sister condition.
Okay. Before I proceed further, can I ask you how much you know about her condition?
Actually, doctor, I don't know anything. My sister came since 2 days in the hospital. She was confused. She was moving in her leg. She was walking. And then she deteriorated. Doctor told me that there is bleeding in her brain, and you are going to do surgery. But till now, my sister is still in the critical care unit.
I'm sorry for what happened to your sister, Mr. Sami, and I understand your feelings and your worries about her. If you allow me, I can explain to you everything about her condition.
Yes, doctor, please.
Okay, as you have mentioned already, she has been brought to the hospital because she has collapsed, and we did brain imaging for her. We discovered that she had bleeding inside her brain. Okay.
Yes, doctor, I know.
You know, your sister, she had before problem with her blood pressure. The blood pressure was high, and unfortunately, the blood pressure was out of control. And this one of the causes that can cause bleeding in the brain. Okay.
Yes, doctor, you are right. I told her many times about blood pressure. She's not taking medication. Yes, you are right.
Yeah. And this bleeding, I'm sorry to tell you that I don't have good news for you today.
Oh, doctor, what? It is cancer?
I understand your words, Mr. Sami, but actually not cancer. Actually, it's not a cancer. Your sister has a severe bleeding in her brain to the condition that she has now, deep coma. I'm sorry for this bad news today.
Yes, doctor, but I know she has bleeding. I told you she had bleeding.
Yeah, but her condition now it's advanced, and she is now in deep coma. I'm sorry for this bad news.
Thanks, doctor, for your feeling. But when we do the surgery, I am waiting for the surgery.
I understand your words, Mr. Sami. Actually, Mr. Sami, we consulted the brain surgeon, and he reviewed your sister condition. And I'm sorry to tell you that he decided that her condition is not fit for surgery, and that so he cannot do surgery for her. I'm sorry for this.
Oh, doctor. Why no surgery, doctor?
Mr. Sami, as I have explained to you, her brain bleeding is already advanced and severe to the degree that she has deep coma. So from the surgical point of view, they discussed her condition, and they saw that she is not fit for surgery, and she will not benefit from surgery, and she will only suffer if we did surgery for her.
So, doctor, you mean that you don't want to do surgery? You mean that your team will let my sister going die? Because if she is doing surgery, she will die. Yes?
I understand your concern, Mr. Sami. Actually, I am sorry to tell you that your sister condition is already advanced. She's in a deep coma because of this severe bleeding. And I'm sorry to tell you that the outcome for her condition is very poor, as there is no also surgical intervention for her condition, so the outcome is very poor. I know how much this information are hard for you to take, and it will increase your suffering.
Yes,
but
doctor.
I'm sorry for this.
So she is going to die, doctor?
I understand your concern, Mr. Sami. I'm sorry to tell you that, as I have mentioned, the condition is advanced, and I'm sorry to tell you that she is dying. She is expected to die in the coming days. I'm sorry, Mr. Sami, for this news today.
Yeah, doctor, very bad news. Okay, doctor, even now she is going to die, and if do surgery, she will die. So do surgery. Maybe there is 1% chance to live.
I can understand your concern, and I see how much you are worried about your sister. But before doing every procedure or doing any intervention for any patient, we should weigh the benefits versus the risks that can be expected. And in your sister condition, the risks are very high, okay, and she will not benefit from such surgery. So this only will add to her suffering. That's why we took this decision in the best interest for her condition not to do such surgery.
Please, doctor, please do anything to my sister. Please do anything.
I can understand your worries, Mr. Sami. But can I ask you, did your sister express any wishes regarding any advanced treatment if she develops such condition, or she has any advanced directive, or she has any lasting power of attorney?
Yes, doctor, many times she expressed to me she wanted to die in home. She didn't like the hospitals, critical care unit like that. She wanted to die in home. So can I take my sister to die in home?
I can understand this, and I appreciate your feelings, Mr. Sami. We can discuss this issue. We can discuss it with our consultant, and also and to arrange this with the hospital team to let her wishes be respected, and to do her wishes. Okay. The other thing that also I want to talk to you is about something called resuscitation. Have you heard about this issue, this resuscitation?
No, doctor. What is it?
As I mentioned to you, your sister condition is already advanced, and she expected to die in the coming days. So what gonna happen that her heart may stop beating at any time. Okay. For some cases, when the heart stop beating, we can do what we are calling heart massage, that we are pushing over the chest to make the heart work again. And giving some medications through blood channels, and also passing tubes through the throat to the air pipe to put oxygen. This is called resuscitation. This procedure we are doing to try to make the heart start or work again. Okay. But as I have discussed with you already, your sister condition is so advanced, okay, and the hope or the outcome is very poor. So doing such resuscitation or such procedure would be harmful for her rather than beneficial. So the best interest of her condition to not do this procedure, which we are calling do not resuscitate. What do you think about this?
So what is the harm of her, doctor, to do resuscitation?
As I have mentioned to you, we will do what we are calling heart massage. This is including pressure over the chest. This can cause some fractures of the chest bone and also some causing bleeding in the chest. And also we can inject medicine in her blood channel. This can also cause problem. And also we will pass tube through her through to air pipe. This can also cause problem. As the outcome is already poor, so doing such procedure will be harmful for her. So this decision was taken in the best interest of her condition. What do you think about that?
Yes, doctor. Yes, you are right. She will prolong her suffering. So it is better to die in peace. Yes, you are right.
I'm sorry for this bad news today, Mr. Sami. I will involve our social worker and also the support team to help you and the family during these hard times. And if you need any support, just contact us directly. And if you have any worries or queries, don't hesitate to contact us anytime.
Okay, doctor. Thank you very much. So when you arrange, I can take my sister to die in home.
We will arrange with I will arrange with my consultant and also the hospital team to try to transfer her to the home with the support that we can give her at the home.
Okay,
doctor.
time is up.
Thank you.
Yes, you can comment on Dr. Mahmoud.
Yes, really, Dr. Alaa did it well, but I was kind surrogate, not like Dr. Alaa. Okay, so the first thing, the only comment in the beginning, when Dr. Alaa tell me how much you know about your condition. First, you have to it is breaking bad news. So do you want anyone to attend the meeting to support you? That is first. And the second, I told Dr. Alaa already, I know she has bleeding. So when he break bad news, she tell me, your sister have severe bleeding. I told him, yes, I know she have bleeding. So that's a comment because I know she has bleeding, but the breaking bad news was she has severe bleeding, not fit fit for any surgery, and she is in critical condition and she is going to die. That is the breaking bad news. That is one. And according to DNAR, she did it well. And according to future plan, yes, express wishes to die in peace. So Dr. Alaa will arrange that to arrange shift Mrs. Mary to home. But social, anyone dependent on Mrs. Mary, she was living alone. That is my comment, Dr. Bass.
Okay, regarding the skills, give him the skills as a judgment. So first one, clinical communication, clinical judgments.
What do you think, Dr. Bass? I think it's satisfactory in all skills. Yes?
Yeah, I think he covered
cover all the comment, only that breaking bad news, some delay in breaking bad news, but I think 1 minute. So I think satisfactory in the skills.
Okay. Just complementary to your comment. I agree with you to advise or to invite someone to this scenario to support him. And he can ask, what do you know about your sister? In order not to repeat something the patient or the relative knows. As in this scenario, she said to you or he said to you that I know there is bleeding. So what's new? Maybe it save some minutes or some seconds at least for the question of who's dependent on your sister or with whom she's living. This question is very important at the end. Why this question I have to ask? Because not only the brother need a support, maybe daughters, maybe sons,
Yes.
maybe other family members. So you don't know who's living, who's dependent, because you didn't ask this question. However, you cover most of the point, advanced directive. But I prefer also to mention the fast track discharge. Whenever suitable, we can arrange fast track discharge. Means that we will send your sister at home if can be done, and she can die inside the home or with her family. This is her wish, and we respect so, and we can do so, along with the situation stable. If the patient situation is stable, so we can do so. Okay, so always activate the fast track discharge. Whenever,
we will tell Dr. Bassem the surrogate that we will
yeah,
activate fast track to
discharge, yeah, this is
discharge
yeah, it's a
to
term of a team. They can do it within hours if can be done, in order to let patient or to respect and to do what the patient wished already. Okay, because she wished so, and it facilitates also the mechanism of being with the family, and the family also will be, I will not say happy, but they will be satisfied that the family or the patient will die within them, okay, or between them. This is the second point I want him to mention. The advanced directive already mentioned. Yeah, the surgery was not able to do it because the surgeon itself or themselves said we cannot do it. She's not fit for that. I prefer also to use the word of quality of life. Whatever we will do, the quality of life will not be changed. He mentioned the outcome, which is also good. The outcome will not be changed. Also, the risk and the benefit he mentioned, always we weighs both of them. Whenever the risk are higher or outweigh the benefit, we are not taking this step. But if the benefit are higher or outweigh the risk, we can do it. I mean the surgery. The DNR is supposed to mention it early. Whenever you are saying the surgery is not fit or she is not fit for the surgery, we cannot do any surgery. Another bad news, or it's not bad news, you can say the team also decided that we cannot do resuscitation for hair. What is that, doctor? What do you mean by resuscitation? And in our medicine, we call it DNR, do not resuscitate. And you can now explain what is the DNR. In order to also not to harm her whenever the heart stop, and this is expected, by the way, expected to happen within days. We didn't add anything from our mind. It's written in the scenario. Within days, the patient will die. Means that the heart will stop within days. So whenever the heart will stop, we will not do what we call it resuscitation. It's the heart massage. It's running to the chest and doing pressure over the chest, putting a tube inside the air pipe, trying to help the heart to beat again, using some medication. Sometimes we give electric shock. Okay, and all of them in hair condition will not get benefit, or it will not add any benefit. Instead, it can harm hair, it can break hair bones, it can do injury to the lungs, the air pipes, and again the outcome and the quality of life will be still low. This is what I want to add as a compliment. However, the all discussion went good. I think also all the skills will be perfect or satisfactory, so he can get a full mark.
yes.
Don't forget only to add and invite someone. It's very important, not in this scenario, in any breaking bad news with patient is dying. Please, this is the most top important scenario you have to invite. Patient is dying. What you want to do more? So the invitation here is I think it's like something is vital. You can help the one sitting with you to prepare him first of all, prepare bad news, and he will have a support by adding someone to the scenario to the conversation. Of course, no one will be there, but I mean the invitation itself. The other thing, this scenario usually comes as angry sister, angry son. I faced this scenario in Madi first attempt for me, as you know, Dr. Mahmoud. It was angry, very angry daughter, and she asked about the NGT feeding and other support. However, the same idea and the concept is the same. ICH, advanced one, because of high blood pressure, and the bleeding is very massive. Nothing can be offered. Patient is dying. So the scenario was about palliative therapy. Not as in this scenario. It looks like, or it sounds here like end of life because within days the patient will die. But the other one was maybe the same idea. I think also end of life. Patient who is dying and nothing will be offered. She asked me about the NGT and the feeding, and it wasn't suitable to start it because the patient already dying. No need to even think about either feeding by oral or by mouth because she is in coma, or NGT because she is also dying, and she had aspiration in the scenario. Let me add this point, because the scenario was ICH, yes, but the patient had pneumonia because of aspiration. So it's not suitable to say, yeah, we can start the feeding or NGT feeding since she's having aspiration. So what you can offer? Only IV fluid. Okay, so you can give, if she asks particularly about the point of feeding, will you give her anything? You can say we can give her some fluid through her blood channel. What? Yeah.
And DNR, this scenario was written in scenario, Dr. Bassem?
No, it wasn't there. Just palliative or end of life without mentioning the DNR. I didn't raise it, to be honest. What they minus me when I tried to convince the daughter or to stop her when she's shouting, no, please do something for. I was saying for her, okay, I appreciate worry and so on. So they wrote for me as a negative feedback that I interrupted the daughter. So they minus me 1 mark for this thing. And I mentioned this part before as a feedback.
Yes.
Any surrogate is talking, let him finish his talk, then start to comment. Don't interrupt him for any reason, even if you are appreciating his worry, if you are appreciating or you are trying to calm him down. No, let him finish his reaction because they are taking this seriously. Okay? I said it before and I'm repeating this advice. It can minus you in the clinical communication. Okay. Anyone has a comment or question? So,
yes, Dr. Bassem, in this scenario, we
yes.
can also involve the bereavement team because I was
Perfect.
hesitant
Yes, sure.
She didn't die yet, that's why I was hesitant.
Yeah. I mentioned in my scenario spiritual team. The bereavement, yes, I mentioned this team and the spiritual team. So the team assigned for the religious issue. So they can sit with the family according to the religion, either whatever. So they can also support them in this way. So you can add it. No one commented on this as negative feedback. But I think it's a good thing to mention. Either bereavement team or the spiritual team.
Can I add something, some comment regarding the fast track discharge?
Yeah. Go ahead,
It's a very good thing. Candidates overseas mention this, but we need to understand what is fast track discharge means. It is a paid service, so the hospital will fund this. So a better way to say it, if it's not clear from the scenario that the patient is dying from this scenario, the patient is dying within few days. So fast track discharge is only suitable if we think that the patient is not actively dying. He's dying, but it's within weeks, not within days. So the fast track discharge is there for to be funded for carers to come home and to take care of the patient who is dying. For example, a patient with pancreatic cancer that is already metastasized and the expectancy of the patient is 1 month or less. So this is a scenario that's suitable for fast track discharge. But if you are not sure, if you don't want to get into this hassle and you want to mention the fast track discharge, and I think in the overseas centers it will sound very good that you are knowledgeable, but you can say that the palliative team would have to come and to assess, and the palliative team would give an advice usually. Oh, this lady can. Basically, their review is needed for the fund to be granted. Okay, whether we can send the patient home with fund for the carers, so the family would not be paying for that, even though here in the UK that some certain parts of the caring in the caring in patient care, families can give some extra money to facilitate certain things. So one of them is the fast track. Fast track is going to be funded by the government or by the hospital. So usually it's better to say that the palliative team would come and review her wishes. If she had a spiritual need, this would be fulfilled. The team in the hospital that do that is called chaplains. Chaplains can be Muslim, Jew, or Christian. There is 3 chaplains usually within the chaplaincy department. If she does have any, if it's a younger patient who came with accident and he's expected to be died, organ donation opinion. So the palliative team is the team that is going to assess the situation and provide opinion regarding continuing care. If palliative team said that it is his home setting is acceptable for the carers, the care, it's better to be done in hospital. The scenario in this that the palliative team has assessed and the patient is not allowed to be sent home to die with his family as his wishes because he had needs that or his home is not suitable to provide this care for him at home, and the family is angry. So this is a scenario. Another thing is the term fast track discharge is suitable for a patient who we are not expecting to die within days. It's within weeks. Third thing is the virtual ward. Virtual ward is not suitable for dying scenarios or end of life scenarios. It is for a condition that it is require blood on every other days to be done. So someone will come and get to do bloods for the patient, to take samples from the patient, and doctors need to review on that. And the patient doesn't want to stay in hospital, and making him to stay in hospital may cause him some harm. So they use the virtual ward for that. Does my explanation made this clearer?
It adds all this information. Thank you. Because you are living there, so you know the experience about these things we are not really familiar with. Anyway, what we mentioned that we will activate and we will see if it's suitable or not. So don't open it as clearly it will be done. It will be done under certain situation. Okay, this is I always saying. So don't offer it without saying that if the patient's condition is stable or the team will be assessed as Dr. Omar add. Okay, so it's yes suggestion, but it's not 100% or no guarantee that it will be applied in your scenario. Okay, but you can offer it respecting the wish of the patient himself.
So for the
Sorry?
For the surrogate, when the surrogate, the scenario asked the question, can my mom come to home to die at home or something like that? You can say the palliative team would review that. I will note your, I will document your wishes
Yes.
for them to review, and they will have a chat with you
Perfect.
about that to arrange that to see if it's suitable. We do
Yeah.
have some solutions for that. I would leave that for the discretion to advise. He will
Perfect.
say, okay, if you want to know more, you can give him, sometimes they might arrange fast track discharge, sometimes they might arrange some suitable temporary solutions, and it's for them to advise.
Perfect. Yes. Okay. Thank you, Dr. Omar. You always add beneficial comments. Anyone want to add a comment or to ask question regarding both scenarios today? So one scenario was about end of life care and the other about counseling patient for insulin. Anyone has any doubt about both scenarios? Clear for all? Dr. Mahjoub, you want to comment?
I want to comment. Yes, I want to ask about the steps of the first scenario. The second scenario, actually, the doctor he did great, mashallah. And also the surrogate is calm because
Yes.
it's in DNR scenario. Usually the surrogate will be so angry and he will not agree to let his relative die smoothly. But I mean, I'm just asking the steps of the first scenario in such scenario. So what I will do first, I will give the result of the
Introduction as usual,
yeah.
and the background of the patient. What do you know about your condition? The expectation. What do you expect? Anything on your mind? Are you thinking something in this scenario or in this the time or this meeting will be discussed? Then, yeah, do it as a concerning news. We have a concerning news. Okay?
Then in such case, if the patient refuse insulin, I will explore why is refusing,
Exactly. Yeah,
and then I will offer the solution for his
perfect.
يعني for
For every reason.
yeah
For hypoglycemia, I will offer the liver. For the injection phobia, by the way, insulin came before as a phobia from the needle. So you
yeah
can assure him it's not big one. It's just a pin, very small pin that it can just break your skin without even feeling it.
yeah.
Okay, it's a pin with a small pin in this way. So
So
you
I
will
will.
feel the prick only without any pain.
So I
Okay,
explore why he's refusing. Then I will
exactly.
offer. Then will I will offer the solution for his
Yeah,
يعني
for his worries,
أنا
whatever the
yeah
worries. Yes,
yeah. Then after that, if still he is refusing, I will express the autonomy for him. And I mean, this is
yes,
complete. You after I will give him the risk and the benefit and disadvantage of
exactly.
using that medication. I will give
Mhm.
him first the advantage and disadvantage. If still, I will express that we will not go, we will not enforce him
Yeah,
to do, for example, that, and I will show
mhm.
the autonomy for the
Exactly.
examiner.
Still,
And
if he's
after that,
refusing, yeah, a
I will
meeting.
give an offer with me with a consultant meeting or
Perfect.
something like.
Yes, yes. So
Thank
I
you.
will arrange a meeting with the consultant. He will sit with you. He had a more better way to convince you and to help you to understand more about this insulin.
And finally, I will conclude. I will give him like brochures or websites
Of
to read
course,
about that
yes,
one.
yes. But the
Thank.
support, as usual, support, occupation, and driving,
Yeah,
alcohol, smoking is very important in the first scenario,
yeah, yeah,
because
yeah.
all of
Thank.
them can affect the reading of blood sugar, the
Yeah,
control of blood sugar, even the hypoglycemia and awareness can be
yeah.
percepted by the alcohol,
But
right?
regarding the offer, another option, I will not give option. I will just refer
No,
him to the consultant
exactly.
who the.
Unless he will ask, yes, there is possibility to have another option or there is an alternative. However, the insulin was made as a decision made by the consultant in the best of interest.
Thank
If
you so much.
still, yeah, if still, then arrange the meeting with the consultant for the refusal and for the alternative. This is in
Thank,
summary how to do the first thing. Most
thank
welcome,
you,
doctor.
thank you
Most
so
welcome.
much.
Most welcome. Okay. Anyone has a comment or question or any doubt? Okay, so sound clear for all.
Dear
Thank
Dr.
you.
Bassem, thank you
Yeah.
for your time. Thank you for your time,
Most
Dr.
welcome, Dr. Mahmoud. Thank you to Dr. Mahmoud and Dr. Ala.
Thank you,
Sorry,
Dr. Bassem.
yeah, most welcome. Sorry, Dr. Salma, because she joined late, but usually when we start, both participants already connected and promised to be doing the both scenarios, and they saved the session, so I cannot stop the both discussion. But I will try to compensate with the Dr. Salma, as I mean. So we can now thank Dr. Mahmoud again and Dr. Ala and Dr. Omar for adding always usual and valuable comment. Thank you everyone, Dr. Mahjoub, all participants today. See you tomorrow inshallah with the short clinical day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. No worries,
Good
Dr. Sabah. It's okay. No worries.